So I'm just going to start with a little bit of housekeeping and a bit of an introduction on LA Link itself. But yeah, for the start of this session, which we're focusing on putting community voices at the center of access to long-acting medications. And what is LA Link? So LA Link is a recurring online seminar and workshop series hosted by the Center of Excellence of Long-acting Therapeutics here in Liverpool. Uh, and each session is featuring experts from across academia, industry, global health, regulatory bodies, community activists, affected community members, all sharing insights on science, strategy, implementation, and of course access, which we're discussing today, of long-acting technologies. The overall aims of LA Link are about highlighting research, sharing lessons learned across different disease areas and geographies, which I think we'll be learning a lot today. Strengthening connections between global partners, revealing new potential opportunities for partnerships and pilot programs, supporting evidence-based decision-making for long-acting products in development and their deployment and provision. So the agenda for today, just introductions for myself, Layla Davies, as joining from CELT also. She'll be giving a short introductory to the topic itself. We then have a 5-person panel on the topic of today. That will be from Ketho Angami, coming from India, Belinda Ameterra from South Africa, Osei Boateng from Ghana, Jacque Wambui from Kenya, and Shatyam Issur from Mauritius. We'll then also be having a audience Q&A for any questions that come up during the panel. I'll just mention about how to add those as we go through. Kind of a theme-focused discussion as well. So it'll be open for comment as well as a Q&A, and then just a little bit of a wrap-up and next steps. So the panel will be grouped with a number of questions that we prepared in advance of the session. Those around clinical trial design, as well as inclusion of the community, from the design of long-acting therapeutics to the reality on the ground, the delivery cost and staying in care in relation to long-acting medications, as well as the access to medications in LMICs in particular. Trust, communication, and miscommunication, and what long-acting success should and does look like. And then we'll have some more general questions across the panel, as looking on a wider view and looking forward about what our hopes and expectations are for the future. So just some light housekeeping about this session. So the session is being recorded. The Q&A has been enabled, and if you do want to add any questions while we're once we get started, please just click on the Q&A button at the top, and then click on the Ask a Question on the right. Audio, visual, and screen sharing has been disabled for most of the for anyone else joining outside of the panel and the core group. However, if you would like to raise a question or have your audio video put on outside of the Q&A, please just raise your hand, and we'll a member of the core group will unlock your audio so that you can ask a question or ask a comment. Hopefully all of that's fairly clear. I'll just check that we've got, I think we are waiting on one of our no, I think we have everyone from the panel. Layla, I don't know if you wanted to go ahead and start your introduction to the topic.
Of course, thank you, Andy, for introducing the session. And good morning and afternoon to everyone, and thank you for being here. I want to start by naming something we see repeatedly in global health, in the global health sphere. Populations are often missing from research and design processes are usually the same populations more likely to be left behind by the final product. That includes people living in poverty, women, older adults, people with low literacy, and sometimes entire LMIC populations, including rural communities. So this creates a growing mismatch between disease burden, research evidence, and actual product design. Here, the pattern we don't talk about enough, I think, is that a product is developed, goes through regulation and the approval process, and then someone asks at the end, will this actually work in the places that need it the most? Or can the health system deliver it locally? Will communities actually trust it? Can people afford it? And by that point, it's already quite a bit late. The design has been fixed, and the people most likely to benefit from the design have already been left out of the process. So the problem is about where access sits in the system, we think. In the current model, key decisions are made early, but target populations, delivery models, and product characteristics, without fully accounting for the context in which these products will actually be used. So by the time questions of access are raised, the opportunity to meaningfully change the design has already passed. What we think here in CELT is that what's missing is actually a model where access is treated as a core design parameter from the start. That means asking different questions, but earlier. Do target communities actually trust this approach? Does the design reflect how people actually live? Does the delivery route fit the infrastructure that exists? And who will administer this? And are they available in sufficient numbers? So this is what access by design is addressing. And CELT is currently developing access by design as a framework with community members to integrate access into product design from the very beginning. This is not a consultation after the fact. It is co-design with the people who make these interventions work in actual sense. I want to mention that these particular speakers today, some of them are part of the Access by Design community working with us to develop this framework. Others bring experience from parallel work in community engagement and health delivery. So the speakers today are not here as representative of abstracted communities or as voices invited to validate decisions that have already made. They are here because they lead the work that makes access real on the ground. They know what it takes to deliver interventions in contexts where infrastructure is inconsistent and trust has to be earned. Where systems are already stretched, that knowledge is important and vital. It is central to the work we're discussing today. So I'd like to thank the speakers for being here today. And that brings me to what this means in practice, what you can actually do on Monday morning at your desks and doing your day jobs. If you design health products or delivery strategies, please build community and system engagement into your development timeline before key decisions are actually fixed. Treat context as a design input, not as a constraint. If you're part of a review or advisory structure, ask when you are being brought in. Push for earlier involvement. Your role should really be shaping the questions being asked, not only reviewing the answers. If you fund research, require evidence of upstream engagement and real-world feasibility. Build access criteria into grant design. Don't treat implementation as a separate budget line. It is actually, in our opinion, part of the science. This is what access means, but this is what access by design actually means. It is not an add-on. it is a more realistic way of doing research, one that needs to be taken seriously. Where and how these products are actually used is vital, in our opinion, in product design. Thank you.
Thank you, Layla. That's a great introduction. And so I'd actually like to introduce our 5 panel speakers in a bit more detail. Hopefully, as we go through, just if each of them can just let me know that that your audio is working okay still. So I'll start with Ketho Angami from Nagaland, India. A founder of the ARK Foundation, a community health organization geared towards education and capacity building to inform effective advocacy. Hopefully you can hear you okay, Ketho, if you mind turning your mic off on.
Yeah. Andrew, yes, I can hear you.
Great, fantastic. Belinda Ameterra from South Africa, a community activist who's worked as part of the AIDS Clinical Trial Group and Bowen Research Group, and has been a champion of TB and HIV research participation in her rural communities, where unemployment, stigma, and treatment remain pressing challenges. Belinda, just want to check that we can got your microphone coming through. Hello, Belinda. Sure if we have audio for Belinda. I'll just move on just for now. Osei Boateng, founder of the OKB Hope Foundation, which has delivered free medical care to thousands of people across rural communities, as well as a co-founder of One Health Plus, a digital health platform which enables individuals to fund health services for themselves and others. Can I just check your microphone's okay, Osei?
Yeah, I can hear you.
Thank you very much for joining. Jacque Wambui from Kenya, regional CAB coordinator at AfroCAB, who has played vital roles in the revision of national ART guidelines, antiretroviral treatment guidelines, in Kenya, as well as having worked with the FASTER pediatric and adolescent CAB in the past. Which has also had success and advocacy for the use of antiretrovirals in women of reproductive age. Can I just check that your microphone's okay there, Jacque?
Yep, I can hear you. I hope you can hear me too.
I can hear you perfectly. Thank you. And finally, Shatyam Issur from Mauritius, a consultant for the European AIDS Treatment Group, an academic lecturer in the University of Mauritius, as well as a senior fellow for the Atlantic Fellows for Health Equity. So I just wanted to check if I can hear you okay, Shatyam.
Yes, all good.
Fantastic. So as I mentioned before, we'll go through a number of questions with each of the individual panelists on a range of different kind of subheadings within this topic area, clinical trials, healthcare provision, as well miscommunication, delivery, and then we'll have some wider questions that will be directed at all the panelists. So I'll just get started. So Shatyam, thinking about clinical trials, if we recognize that clinical trials are the starting point of addressing access considerations, what needs to change, in your opinion, in the design and planning of research studies to effectively involve the community voice?
Can you hear me? I'm sorry, Andrew. Can you just repeat the question? I had an issue on my laptop on my end.
Of course. So this is regarding clinical trials. If we recognize that clinical trials are the starting point of addressing access considerations, what needs to change in the design and planning of research studies to effectively involve the community voice?
So In one line, if I can say, we need to stop treating access as something that begins after regulatory approval. Access begins at trial design, and this is something that we all need to understand and agree on. And this is really, really important, because once we start accepting that access starts from the very beginning, this is where we start to embed equity consideration in the earliest planning of clinical trials, right? And what needs to be changed, I would say, is the approach to clinical research. Instead of just asking, can participants fit the trial? It's now, I think, time for us to start whether the trial fits participants' realities. And this is where we would be able to start designing studies around real world, living realities and conditions of people who, at the end of the day, are the ones who would be benefiting from the drugs that's being produced. So what needs to be changed in the design and planning of research studies, I would say, firstly, we need to review eligibility criteria, because for long we've seen that clinical trials have a long list of exclusion criteria, which at the end of the day doesn't make sense, because people who are excluded from clinical trial at the end of the day are expected to be the one who would receive or be the end user of the products that's being designed. So we cannot say, for example, we're excluding people who use drugs from an HCV long-acting trial when we know that the disease burden of HCV lies among people who inject drugs. So it's, again, you cannot just favor healthy adults or exclude women, exclude older population, migrants, LGBTQIA plus communities, or even people with disabilities or comorbidities. It's important that they are also included in trial, and this will give us a proper picture of who at the end of the day are the end user and how the medications are interacting and how at the end, access would be made possible when they have been included in clinical trials. The second thing that, in my opinion, is really, really important is also about selecting the trial sites, right? Because we've seen that currently most of the clinical trials that's happening, it's happening in the global north, while disease burden mostly concentrates in the global south. And people in the global south, we have multiple identities, intersecting identities, different realities that we're living in. And this is sometimes missed in clinical trials, which happens in the global north. So it's also important to start considering where clinical trials should happen, and for it to become as much as representative as we want it to be to the real life conditions and to those who at the end of the day would access the end product. So I think one last thing that is coming into my mind right now is also to think about the endpoints earlier on. And one of the biggest gaps in clinical research is that many trials are designed around what matters most to regulators, to sponsors, or to the investigators, researchers, but not always around what matters most to the people living with the condition. So alongside answering the question whether a drug is working, like biologically, is the drug working? It's also important to seek answers such as, realistically, who will be able to use the drug at the end of the day? Will it improve the quality of life of XYZ population, or the population where the burden currently lies? Will the people accept the drug? Will it reduce stigma? Will people in XYZ setting, rural, urban, peri-rural, be able to use it? And how can we make access easy as much as we can from the early onset? So this is where the expertise of communities lies, I would say, as we are able to provide an answer to all these questions that I've been asking. And lastly, I think what's important is also to talk about post-trial access planning, which include affordability, availability, licensing, whether to consider regional manufacturing, procurement, how would the national rollout strategy look like? These are all discussions that we need to start having before even the trials start, because we've actually seen it in the field of HIV. For example, scientific breakthroughs alone do not guarantee equitable access, right? ARTs existed for years before many population could access it equitably. So we don't need to repeat the same mistake and lose people that we know, lose so many lives. Clinical success without equitable implementation is incomplete, right? So we need to change the way that we've been doing these implementation. Over to you, Andrew.
Okay. Well, thank you. Those are really, really essential points in that the planning and design of the endpoints and post-trial access. And yeah, I think I wanted to question if Belinda, Belinda, are you able to unmute? Yeah, you can hear us. Okay, Belinda?
Yes.
So a question for yourself, thinking about how you've worked with as part of a number of research groups from a community perspective. How often are people like yourself actually included in the decision making? And what are some difficulties you've faced in some of these roles in research?
Yeah, like Shatyam said now, we are hardly included in decision making because it seems as decision making is for the for the trials and not for the people who are the participants. And it is very difficult because we bring our stuff to the table, and whether they are using what we say that comes from the community, it is very hard to say. And like Layla said, by that time when they ask us, the stuff is already made, and then it's like you cannot crush the people, the participants, because it takes time and trust. If they don't have trust in the formula, then it is hard to make them a participant or to get participants to do that. And this is what is really missing, a participant in the decision making, because who best can speak about what they're going through with what they're going through being a participant. Because yes, the doctor or the research nurse or whoever are part of this decision making, yeah, they did have injections, but injection or using so many tablets for HIV and TB, it's different. Like if I look at that medication, I already feel ashamed for the participants' part, and because they're staying in rural areas, it is difficult to get that medication, and the language barriers and the partner protection, that is not there. But most of all, that lacks is sanitation, the toilets, and clean water. Sorry. That is never mentioned anywhere to assist the participants, to assist helping bring them to the table. My question always is, why must a participant be halfway the sky and not in the sky? So for as long as a participant is halfway the sky, you get studies or protocols or whatever, and that is the biggest challenge for us. You get it, that it doesn't go any further due to not funding, but the effectiveness. That is what happened. And for me, it is very, very sad if those things are not addressed. We take them to the table many a times, but we are ignored. It's only the people that the political leaders and the doctors and the nurses or the sisters, they are part of that decision, not we on the floor or the participants. So I just pray that one day everything will work out for the best, for the people on the ground to get what they need and what they fight for. It always takes so long, and what they don't understand is that everything costs money. What government do is when someone dies in our area, if they from Uganda or wherever, it counts to our total. And then they expect us on the floor to give reason why that person passed away. Maybe they came here half dying and, that's the last straw. But we are kept accountable for all those things. And that is also a huge barrier for us. There's no protection.
Thank you, Belinda. Those are really powerful points, particularly around those issues of funding and facilities, and particularly in rural communities. Shatyam, another question to yourself, also in relation to clinical trials, before we move on to more the other topic heading areas. In your opinion, what does, with community involvement in the clinical trials, what looks more like this in practice than, say, tokenistic inclusion?
Thank you, Andrew. So I think to answer your question, I would echo what Layla said in the beginning. She rightly said that meaningful community involvement is not about inviting community representatives to validate decisions already made, right? But I would even add on to say that meaningful community involvement is not about really inviting community members to just recruit people to participate in clinical trial, because this is something that we're also seeing nowadays, where community members are just here as a strategy to recruit people to participate in trial. And again, that's not our role. For there to be meaningful engagement, we need to be involved as early as possible. And by that, I mean that our input has to change the trial, both at the scientific and at an operational level. And by that, I mean that before protocol finalization, we should have a say in terms of what priorities we are setting. We need to have a say in terms of who to include or who to exclude in terms of inclusion and exclusion criteria. What would be the recruitment strategy? What would be a retention plan? How would the informed consent document look like? We should have our say in all these different levels when it comes to clinical trial. What would, for example, a reimbursement model look like to participant trial, or even have discussion around post-trial access planning, like I said earlier on. So it's important to consider that community representatives should also, beyond, I would say, community advisory group, have a say in terms of steering committees or even governance board, where together with researchers we're able to make and take decisions. And by that, I mean that we don't want to be consulted only once. We don't want to be there only to validate decisions, but we need to have clear mandates, clear roles, or even decision-making influence, together with all the people who's associated with the clinical research. And it's important here to consider that for it not to be tokenistic, is that we need to include diverse population rather than having just one representative or one representative of a patient voice. We need to acknowledge that people have intersecting identities, and this needs to be reflected at all levels of the research. So I know one person is not able to bring that, and sometimes even a community advisory group is not able to bring that. So it's really important that we're able to, at all levels, involve as much people as we can. And by people, I'm talking about communities here, because communities face difficulties when it comes to participation. And it's also important to acknowledge that, for example, by acknowledging that by translating material in lay languages, for example, or translating it in languages that's easy to understand for community members, having accessible meeting times, providing disability support, for example, or even childcare support, travel support, so that people are able to engage and participate in clinical trial, or even in design of the clinical trial. And I think mostly it's important that community members should be fairly compensated for their time. Historically, I think compensation to communities was seen as a symbolic token for their participation or for their involvement, and we need to start shifting this narrative. Today, we need to see compensation as recognizing the real value of the expertise and the time that community representatives would bring to clinical trial. And when we start recognizing this expertise, this is where we'll be at the same level and community members will be seen as important partners or equal partners to the clinical research. And I think I can go on and give many examples on how to make community engagement more meaningful at different levels of clinical trial, like proper budgeting, trust building activities, feedback loops. But I think if we need to put it in one line and know whether a clinical trial will really be meaningful, I think there needs to be only one question answered at the end of the day. If you can point out to something in the study design that changed because of community input, this is when meaningful community engagement happened. And if you cannot, then probably the engagement that there was within that project was not really meaningful.
Can I just add something to that, please?
Yeah.
Yes, go on,
Yeah.
Belinda.
Okay, so when the participants or community itself is not recognized in what Shatyam said, it leads, and it happens a lot here by us in Worcester, it leads to that people think they are used as guinea pigs, and their blood, when they have to draw blood, their blood are being sold, and that causes a lot of defaulting, and people, does not want to participate in a clinical trial or whatever. So a participant's voice in a community is very, very important for us to make a success of what they try to give, the new medication that they try to give to the people.
Absolutely. It's a really, really valued point. Thank you, Belinda. So moving from that kind of clinical trial design, but further into long-acting design of long-acting products and their implementation in real-world settings. Ketho, checking, yeah, still online.
Yes.
Coming from a place like Nagaland, where there are, of course, marginalized communities and intersecting identities, as Shatyam had mentioned with clinical trials, what are some things that are often assumed when a product is designed or introduced into these communities, but then do not work when it is used in real life? What are they overlooking, or what are they not seeing in the communities?
Well, to begin with, a little scenario of my state, as in Nagaland. So it's hilly terrain with lots of big mountains and rivers, things like that. So when it comes to our access issues, all those becomes a factor for consideration. But also the part of the state shares a cross border with a region of India, which is called the Northeast region. And we have seven brothers and one sisters, which are all more or less the same of a geography. Comes the monsoon, there is floods everywhere, roads get disconnected. The heavy rain with thunderstorm brings erratic electricity problem, things like that. And also to say that this region holds the first and the second plus the third highest HIV prevalence rate, the burden of highest HIV prevalence in the country, mostly fueled by injection drug use and sexual route of transmission. So given that scenario, any product that is in the pipeline or has come before and are yet to come also, I believe many of the regulatory and the approval as far as the medical and the scientific perspective are definitely considered. However, one thing that over these years of my experience in working with the community, I've seen that most of those product access designs are purely based on scientific evidence and on a medical perspective. However, the challenging issue, or rather as to why it did not meet the result that it is expected, is because I see that the operational issue, how it should be rolled out, the implementation and the uh, operational aspects are often overlooked in most of all these developments and product designs. So I say this, for example, when it comes to a region like ours or my state, as in Nagaland, the lack of proper infrastructure, because any product that is to be launched and to come into the public or private settings for access to any person who is in need has to come up with certain arrangement, as in the supply chain management has to be considered, the storage has to be considered based on the type of the product, whether if it's to be the injectables, whether there's enough manpower at the service centers to administer the drug to the patient. So all those factors becomes a problem. And one latest example that I can also give is the first-hand experience that I had today. Today I was in one of the district TB center where I came to know, where the staff there themselves reported to me that there was a shortage of levofloxacin. And therefore, if the supply chain mechanism by the central TB division has not been sorted out, then there will always be a shortage and also resulting in stockouts. We have also seen this in the field of HIV before. We have also seen this in the field of viral hepatitis also before. So those factors I see that are not taken much into consideration. It's just one side of the coin that, okay, this is the product. It has good sensitivity, specificity is there. The efficacy has been proven. WHO has approved it, recommended it, US FDA, so on and so forth. And then when it comes into the regulatory authorities, get approved, and then it's just a massive launch of that particular product in the country. But like I said, if those ground level situation of the operational and implementation aspects are not being considered and prepared, then the product often results in a very, very unsafe delivery. That is what we have seen in many of the product also. For example, the rollout of the tenofovir, lamivudine, and dolutegravir experience also. The treatment literacy was not there. The community preparedness was also not there. Therefore, when it was rolled out initially, there was a lot of apprehension, a lot of hue and cry. The PLHIV were not well, so much of a forthcoming to receive that dolutegravir based regimen. So I would say that in addition to all those scientific and medical aspect of any drug development, it will also be very, very necessary to actually see the ground situation as to how the implementation aspect should happen and how the operational challenges which are likely to happen can also be considered and strategized accordingly. Over for now, Andrew.
That's really key points, particularly I'm going to particularly thinking about some of that kind of operational challenges and the supply chain management aspects that you were mentioning. I think Osei, you might have some really intriguing points to raise in respect to this. So you built your foundation set up mobile health vans because people could not reach those kind of facilities in a similar way that Ketho was describing. I was wondering if you could talk a little bit more to that, but also thinking on if a new product was being designed or being introduced in your communities without thinking about the realities of these operational challenges, what is likely to go wrong?
Yeah. Sure. And once again, thank you so much for the question, and also Ketho, thank you for the contribution. And so our work has been to focus on bringing healthcare to rural and underserved communities. So for communities where access has been difficult, where individuals will have to travel miles just to get access to care, which is also not even guaranteed that once they make that trip, they will get to see the healthcare provider or get the medication that they need. And so our work has been to bring that reliable access into these communities using mobile medical units. And so for us, to put in context, in Ghana, we have about 13.3 million people who live in these rural communities where access is a challenge, and less than 2% have reliable access to care. So, there are two things. You can have access to care and you can have reliable access to care, which means access to care is like, okay, there's a health facility that you can go to, but in terms of reliability, whether you are going to meet with a healthcare provider or whether you're going to get your medication, that one is you go there with the hope. So there's not that reliable access. So what that creates is the mistrust among people. So most of the rural communities or the people that we serve, that has been the thing. They're like, oh yeah, there's health facility that maybe we can travel 2 hours to it. But the problem is not traveling 2 hours. The problem is, okay, even if I get there, there's a long line of people. I'm going to spend 8 hours of my time. And even with that, it's just with the hope that a doctor gets to see me. And if you are looking at these people are people who live in I would say, the informal economy, which means that whatever they sell in their farm, in the market, determines their daily wage. They don't have access to regular source of income. And so for them, it is a big decision. It's more of like, okay, if I don't go to the farm or don't go to the market and travel 2 hours, and even with that, I don't get to see a doctor, that's a very big ask. Yeah, it's basically you're telling me that, okay, how would I get money to feed myself? And if the person is a breadwinner, how do I even get money to feed my family? So they have to make that, constant decision that, okay, do I go right now and forfeit my daily wage, or do I go to the market and get whatever I need to get to feed myself and family and forfeit going to the hospital? And what that end up being is, okay, they would go to the nearest facility or the clinic when it's late. So it's like, okay, right now I don't have any other option, then I would go, because that is like, if I don't go, I would die. And so that is what we are trying to bridge with the mobile, medical units. And so if a health product is being designed, what to think about is not just access, right? As the reliable access. Okay, so if someone has, let's say, hypertension, like, you can give the person one time 30-day refill of medication, but after that, what next? Because that becomes, okay, would I get reliable access to these medications every time that I need it? And so then if you're designing a product, that is something that we have to be thinking about. Okay, what is the operational challenge? What are the logistics? Will we be able to make sure that this product is available in a reliable manner? Because what happens is that if someone is on a course, most of the people that we've been working with, right, one of the reasons why they are not adhering to their medication is that, okay, first month I got my medication, second month it was not there, third month I went again, it was not there. So it's like, okay, I wouldn't even take the medications again, because I'm not getting it on a reliable basis. And so what I would say, like, thinking about designing a product is not only about one-time access, but the reliability of the people to get the access to the needed medications or treatment, because that is what builds trust among the people. It's like, okay, I trust that once I come here, I'll get what I need. And one thing that has made our work successful is that the people know that as long as the van is here and I get here, a doctor will take care of me. I'll get what I need, and then I will go back to my workplace. And so we are trying to bring the care closer to them, knowing their reality that they can't afford to miss spending a whole day at the hospital and forfeiting their daily wage, but with 10 minutes or 15 minutes of their time coming to the mobile van, they will be able to get all that they need and be able to still go back to work and do what is needed to support their family.
Thank you, Osei. It's really admirable, and it's really, really interesting points about that reliable access versus just access, which can be spotty and difficult. Thank you. And really those points about that building trust, which can help us overcome over time miscommunication and mistrust and lack of adherence. Jackie, so when thinking about some of the communities and populations that you've worked with, particularly say maternal pediatric populations, what do developers of long-acting products most need to hear from those communities before products reach the health clinics or the ground?
Okay. So thanks for the question. So yes, and thanks for the introduction that you made, and of course to the speakers before. So working with these communities, it's important to note that when these long-acting treatments become available, women and these adolescent young people population need clear, honest, and practical information delivered by trusted peers and even trusted healthcare providers. So first and foremost, at least we know during the trials, the safety and effectiveness has already been studied, right? But what we need to hear is not what the developers may be thinking, right? So we don't want to hear this is exactly what happened in the trial. So we need to hear things it's not an experiment anymore. It has, or rather that it has been used before, and it works as well as your daily pill in some studies. It was preferred because they did think about the virus, not stuff like that. So we really need to think about, firstly, the safety and efficacy of the product. Of course, trying to demystify the fact that even when the product does come, especially in populations of people living with HIV, women living with HIV, that this is really not the cure, but really right? And it's just as good as what has been taken before, but obviously now can be more convenient. Just like a continuance of already what has been happening with such a findings, right? And then, of course, again, we want to think about where are these products going to be delivered, right? And what happens now if I'm not able to reach my facility where I'll be able to get this, this product? What happens if I miss it, right? By a few weeks, a few days, Yeah, so some things, those are the things that we need to hear so that at least when we know we are dropping off this particular way of treating ourselves, when we move over, it will be comfortable and should be as smooth as it previously was, right? Of course, everybody wants to know about the effects of the drug and also the side effects. Of course, and then again, because the long-acting will also come in form of an injection, so there'll be pain. There are going to be side effects on the site of where the injection is going to be. Is it going to make you tired, like the things have been doing, like the other things you were taking before optimal came up? So again, another thing is, if it does not work, can I switch back to what I was using before? Right? So some of the critical things. And then, of course, because women are diverse and we have pregnant and breastfeeding women, so this is a critical question which must be addressed. What are the effects? What happens? It's safe. Will it affect my child when I'm breastfeeding? Yes. And of course, it's important to show that data if there was any inclusion of pregnant and breastfeeding women during the trials, right? And then again, is it for everybody who can switch now to this long-acting? Who does it happen to those who are maybe not virally suppressed? If they are not virally suppressed, They may be the ones who will need the drug more than those who are very suppressed. And maybe sometimes the drug will only be for those who are very suppressed. And then again, what about those with co-infections like hepatitis? And again, for those now who cannot really commit to the injection, right? Can they also now see alternative options for what can work for them? Yeah. So, and then again, yes, as we're talking about now these messages, again, it's important now, who do they want to hear these messages from, right? Because I sometimes maybe it will be comfortable for me to hear from my healthcare provider because, we don't have that kind of rapport. So it would be good to hear it from a person living with HIV who has already switched. So it's good to have these real life testimonials. Again, even if, in the healthcare setting, a good trusted nurse or a clinical officer. But of course, now these nurses and clinical officers also have to be, the capacity has to be built now in terms of the knowledge about long-acting and, of course, now even how to administer, right? And then, and then usually because most of these women and also young people do belong to support groups that have been supporting now this journey of us living with HIV. So this in a woman's and also young people support group in a facilitated conversation where now this person who wants to switch can ask a lot of questions, as much questions as he or she can without any pressure. And then also, we have a lot of trust in our community health workers because that has worked very well. Somebody who will come to my home and discuss some of these concerns in a private safe space instead of now me having to do it to a healthcare provider who, may not have much time. But now when I'm at home, I can have these conversations in a safe space. So, it's also important to know, like, if we do, maybe like sometimes from the manufacturers, we do have the conversation. It's good to hear that now the formulations are being worked on well for this, like I mentioned, for pregnancy and breastfeeding women. And then, of course, that as we are watching these trials, that there's data transparency when it becomes available, so that at least now for the end user, we are not so much in the dark, but we will be going along with the trial and watching what is happening, just waiting for the end product and for us to figure out rollouts and updates. Yeah, so thank you.
Well, thank you, Jacque. I think you actually answered more than one of my questions there, so thanks very much for that. I actually wanted to relay some of the points there that you were just addressing about communication, and that's not a whoops. That's fantastic. Saying that I wanted to then address some of those questions towards, I guess, Ketho. Thinking about that kind of communication to more marginalized communities about what kind of campaigns or methods are useful or are able to be utilized to overcome those kind of barriers in that setting. Ketho, can you hear me okay?
Yeah, I had some problem with my network. Can you please repeat the question again?
Yeah, so I was just following a point up from Jacque there, talking about that kind of communication with the communities. Particularly she was describing from her perspective, but in Nagaland, for example, what campaigns are kind of used or methods with local communities to try to get that message or information to them when a new health option or therapeutic is available, or what's kind of utilized to overcome those kind of barriers?
Yeah, I think we have a strong community advocacy group. Most of our approach are mostly based on activism, but unless we demand, we don't receive. So as much as we don't want to be shouting and giving press release and holding press conference, things like that, unfortunately, sometimes at the end of the day, things do not work out. So what is rightfully ours has to be rightfully demanded, and therefore our advocacy group continue to demand in various forms. We use the legal system also to fight to file court case for any product that is in need based on the right to health framework under the Constitution of India. And we have had series of examples where we have dragged the government, the program to the court, and we have also won many of the cases. And therefore, as of today, as I speak, I can proudly announce that we have free ART, we have free treatment for TB, we have free treatment even for viral hepatitis. But sometimes again, there are too many other factors that does not always work as per our demand. One thing that I see is the profiteering strategy of any pharmaceutical companies or any drug developers, because the price is set so high that even the national program cannot procure it either through domestic funding or through the global fund. And therefore, that kind of advocacy needs a different approach, as in our target of advocacy shifts focus to all those companies, be it the innovator or be it even the generic companies. But also beyond, over and above that, again, once or if that product is not integrated or updated in the national treatment guideline, sometimes all our advocacy and all those market access issues also become a big problem. And therefore, our advocacy also is with the drug regulatory authority. I would just want to cite one example. When the treatment for viral hepatitis of Sofosbuvir came, and then the next DAA, as in Daclatasvir, was innovated, but also it could not hit the Indian market because there was a need for clinical trial. So what we did was we wrote an advocacy letter to the drug regulatory authority, the drug controller, and urging them to waive the clinical trial in India. And we made it happen. And that's how the generic version of Daclatasvir very much was made very much available. And even as of now also, as far as the long-acting, we are in one way preparing the community, and just, I mean, over this couple of few years, we've been informing the community that let's be prepared, because new products are in the pipeline and it will very soon come to all of us. But let's be prepared. Let's understand the importance of why a TB vaccine, or why a long-acting injectables for HIV treatment, or why a long-acting injectables for viral hepatitis. So those are some of the responsibilities that we community are also taking. We are also reaching out to the policymakers that these are something that is going to be very, very helpful as far as the achievement of the SDG 2030 is concerned. But if at all it comes, the country has to be prepared. The state has to be prepared. Just as we, the communities, are also prepared, that is what all those preparedness also has to happen. So while upon advocating for the rights that is rightfully ours through our demands, we also tend to realize that we also have a responsibility to perform on our own. So that is the whole synergy that is going on as well out here.
Thank you, Ketho. Osei, from your experience, what has really worked when bringing care closer to communities and getting over some of those barriers? What has not worked as well, even with recommendations, say with a new treatment or just in general, I suppose?
So for us, what has really worked for us is being able to work with key stakeholders who are already in living in the community. And so, for example, for us, before we get into any community, we do what we call a community survey to be in the community, to understand the needs, to meet with the key stakeholders. And some of these communities, their key stakeholder could be a pastor, could be a chief, could be an opinion leader. So these are people that the community members trust. In some communities that we even go, if they are sick, the first person they go to, or the first place they go to, is the church. Not because they don't know that when you are sick you have to go to the hospital, but they know that if I go to the church, I have someone that I trust that can guide me. So for us, it's very important for us, and it's critical, and for us to be able to liaise with these people, because the community members already trust them. And so it makes the work easier for us. And so what has really worked, for us, is being able to form this partnership with these community stakeholders, and we co-create with them. And what we mean by that is that we don't go there and tell them that, okay, we have a van, we are coming to do this and that. Can you tell your community members to come? It's more of like, okay, let's sit down, let's talk, let's understand what are the challenges you guys are experiencing when you want to assess healthcare. What are some of the issues that are really happening in the community? So when we understand their needs, that is when they can now tell us that, for my community, Tuesdays are the days that these people are around. And so I would say that maybe you guys should come on a Tuesday. I would take it upon myself to let every person in the community know that these people are coming. And what happened is that if these community members know that we are coming through the stakeholder or the person that they respect, it's easier for them to come around, because they already trust this person, and this person has been with them. So if this person is telling them that, okay, you guys should come here, they know that the person has their best interest at heart. So it makes it easier. And another thing is, by co-creating with them, you understand the root cause of their situation. So we've been to communities where we've seen a lot of waterborne illness. Through the co-creation, the community members will tell you that, we don't have a potable source of water to drink. And so then we are able to address the situation from the root cause level, where we can find other partners to come and build, let's say, a borehole for that community, knowing that even if I go to the community, provide them with medications, treatment, and I leave, they are going back to the bad water, which when I come back the next month, I'm going to see that again. And so for what has really worked well with us is being able to partner with these people and be intentional around that. For us, what has been some challenges is also the language barriers. There are different, regions, different, cultures, and diversity in the country, so that it makes it also challenging if you find yourself in a community where they don't speak your language. It's very difficult to even offer treatment. And even if you offer treatment, you are thinking that this person understood what I said because of the language barrier. So these are some of the challenges that we face, because then if someone doesn't speak your language, or doesn't understand, they are reluctant to come seek health care, because it's like, okay, these people don't understand me. Why am I even coming out to even, come and seek healthcare from them? And so that is why it's also very critical to be able to work with these stakeholders who live in both worlds. Like, okay, I understand the community, I understand what you are bringing, and that has been one of the things that has been really successful, for us. And the barriers, the language barriers, and I think Ketho mentioned sometimes the road network could be really bad, that if any seasonalities, whether it rains, it's very difficult to get to these places. And so for us, there are things that we have been thinking around toll-free number. We know that, these people might have access to either a smartphone or not a smartphone, but to even get a call credit to call a healthcare provider to find out like what's wrong with me is a challenge. So something like a toll-free number that we implemented has increase access. It's like, okay, they have a doctor to call. If we give a medication and they experience side effect, they know who to call. So this has been the ways that we are also bridging the gaps when it comes to the mobile care access using the vans.
Thank you, Osei. Some really good points about trust building and kind of overcoming some of those barriers as well. Jackie, I think kind of stemming off from some of the points that Osei was just raising there about that kind of trust building, particularly say you've worked with communities, particularly with maternal communities and pediatric. What do women living with HIV, for example, most need to hear to be able to build that trust and to feel confident in switching to a new treatment if it is beneficial to them? And who maybe do they need to hear that from first?
So yeah, so in terms of the population that you've spoken to, and I think I'll just pick up from my previous speaker when he says that this information is important to come from people they trust. So he's talked about, people like the religious leaders, here in some of the settings in Sub-Saharan Africa. We also like to listen to a lot what our leaders say, and that would be like the chiefs and all that. So usually what we really want to hear, especially in terms of when we're speaking about pediatrics, we want to hear that these formulations will be friendly to the child. We don't want heavy dosing. We don't want some things that are so heavy, because we've had previous formulations that were a bit too tough. Some of them were too heavy and were giving adverse side effects. And then also, when we talk about access and like now me having to find out, to find a suitable product, delivery really must fit some of the real systems, right? So we have already, as they say in our region, we have a lot of clinics that are busy, very busy. So will this particular long-acting formulation will still be able to be delivered in that system? And of course, if it is still going to be as complex, it might not be advisable again for me to switch, because it won't be any different, right? So we have the busy clinics, we have the limited staff. We have, of course, now when we have some of these facilities that are in the rural areas that are a little bit too hard to reach. Again, we need to think about, will that really like increase access, or will it just be the same old barriers? And then because now women mostly are the ones who, or rather, let me just say caregivers are the ones now who really need to be the ones to give this formulation to their children. They also need clear guidance on how these products are going to be beneficial to their children. Not really like giving like complex protocols that they would not be able to understand. And then we also need to think about the acceptability of these products. Like I mentioned, the pain, and then also there's the issues of stigma. If my community still have not accepted the fact that we are just managing a condition and not really like bringing in something new. We really need to eliminate the stigma in terms of now how these products can be accessed. And then I also talked about the frequency of going to the clinic, and of course now all those are going to determine uptake more than efficacy, right? So it's important that we make all these systems comfortable for our populations to be able to access. And then, of course, one thing that is very, very critical, and I think most of my speakers have spoken about this in maybe just in a different way, but it's important to engage communities early. And it was mentioned that my role as CAB coordinator is just ensuring that CABs are in place, just to shape these product profiles, and again, not validate the products at the end, but usually just to go through like the whole process of research and the engagement with communities. So, and again, if it does not work for caregivers and children in rural settings, then that means it will not succeed, right? Regardless of how they say the trial was, worked and all that. So it's important to engage community early in this process. Thanks, and over.
Thank you, Jackie. It is so important to engage communities early in these kind of settings, like you said, and to set up community advisory boards, of course. I just wanted to move to a few questions that were more open to the panelists in general. So I have a first one here of what do you foresee being the core issues of involving community voices in newly approved, newly accessible, long-acting medicines? I don't know if perhaps Shatyam, if you wanted to start, since I had left a few questions since asking you.
Yeah, can you just repeat the question, Andrew?
What do you foresee being the core issues in involving community voices in newly approved or newly accessible long-acting medications? So involving community voice in improving kind of the access to these.
So you mean at like near the end product, right? But early on.
Yeah, the
think
later point.
At a later point, I think that then it becomes more of a tokenistic involvement, right? More like having people there just to validate and say we are like have a tick the box approach. Communities were there, but it doesn't work that way, because at that point we're just there as a scapegoat to make sure that the product is being accepted by people, when this is not the case, and this is where lots of misinformation happened, as Jackie said. So we need to be sure about it, that communities need to be involved at the early onset, and we need to have clear influence on decision making, because once we're involved, we bring a valuable perspective that no one else is able to bring, because we have that lived expertise. Whatever other colleagues just said today, these are experiences that we see on the field that researchers don't have, and these is something that needs to be valued from the early onset. And if we don't value it and we start engaging people from like the late, when the product is nearly available, what would happen is that we'll start facing lots and lots of challenges, and then saying that people are not accepting the drug, or put the blame on communities that people are not using the drug. We build something that's saving lives, but still people are not using it. But that's not the case, right? It's because you have not involved people from the start, and that's why there's lots of misinformation. There's no trust. People don't trust the drug. People don't trust the trial. So it's really important to do it from the start, so that we don't face these challenges and then expect community to be there as the savior, to make people trust, gain trust about the drugs, and it just doesn't work that way. Yeah.
Thank you, Shatyam. I'm not sure if anyone else has any additional points to add to there.
I just want to add that community consultation before the actual rollout also is important, but also at the grassroots level, as has been mentioned a while ago, I believe treatment preparedness through literacy campaigns and programs has to be carried out in a massive scale, because unless the recipient who are going to take all these products, if we are not aware of what is going to be injected in my body, what is going to be put inside my mouth, if I'm not literally made aware of the importance, why I should be injected upon it, so why I should be given any medicine, and why I should be taking all this, if I'm not made aware about through all this kind of literacy, no matter how much of a good product we put it over the national guideline or in the market, if there is no demand from the community, if there is no recipient who is actually forthcoming to receiving that kind of a new product, it's not going to work out. Therefore, I would say that having a consultation with the community, but also a grassroots level campaign through preparedness, treatment literacy, small group meetings like awareness building among the community on all this new drug. What if you take it? What kind of benefit are you going to get it? What are the possible side effects? How can you manage it? All those has to be deliberated. Then I believe any product that is going to come in the country as a national rollout program also is definitely for the good of the people and for the good of the community. But sometimes because of all these dots that usually do not get connected, it becomes a big failure.
And also to add a little bit to what Ketho said, I think what he said is really spot on. Definitely involving them, making them understand, okay, if I take this in my body, these are the side effects that I should be experiencing. Most importantly, having a reliable contact, like, okay, if you're experiencing this thing, you should call this number or reach out to this number, because most of the times we introduce a new form of treatment, and every treatment every person is different, right? And so everyone will react differently to the treatment. And so having someone, or like having a way for someone to contact, like, okay, I took this and I'm feeling this way, what should I do next? It all builds upon the trust, so that the person is not like, okay, you handed this over to me and you left, but more of like, okay, what is the continuum of care? How do we sort of help them navigate the healthcare situation, or the healthcare journey? I think is also critical for people to adopt a new kind of treatment.
Thank you, Osei. Really, really, really valid points. I have another question that I think all of the panelists can kind of answer. Who is kind of missing from the conversation? If CELT, and this is something that we are hoping to plan to do, is running an in-person session with community activists like yourselves, and yeah, obviously industry, academia, others, who is kind of missing from the conversation, and who would we need in the room to have the most kind of impact to have a conversation and workshop coming up with ideas for overcoming access barriers? That's open to Jackie.
I think,
yeah.
Okay.
Can I speak? Okay.
I know that was a question that that triggered everybody at full alert. So I think if the developers are there, the manufacturers themselves, because these are the people who usually will make a product, and I hope I won't be quoted to make money. But for us now, it's, I mean, for the recipient of care, it is something that is going to save the life. It's something that's going to manage the disease. So it's important, if they are there also, we have a conversation with them, because for a long time, there's we started having the conversation with the researcher, which is good. But then now with the developers, with the ones who actually thought about that drug and what they think the drug is going to do, I think it's important to have a conversation with them. Because one thing is putting the profits aside, it's important for us to be able to access that medication. So when I talk about profits, not to think about how much money they're going to make, but how many people they are going to reach with their products. And of course, now communities can be the one to steer that conversation and ensure that the product is rolled out and taken up by many. Over.
Thank you, Jackie. I think, Belinda, if you wanted to go ahead, and then Shatyam.
Okay. I think the participant, the community member, I think Jackie has mentioned it now. It's very important, because I feel that decision making about the drugs and things should be around the people, because they are the people that will be participate in this protocol study. So as for me, it is important that the participant should also be part of that. From there, they will rebuild trust of previous challenges they had, and we're not happy about that. Sorry. Can't speak further now.
Thank you, Belinda. No, it's really essential that the participants are involved also, like you mentioned. Shatyam, did you want to add
Yes,
in?
I think one population I would say which is actually overlooked would be people who dropped out of clinical trials. They also need to be included in these conversations, because at one point we feel like it's like a disengagement or like people don't want to participate. It's like a failure, but it may be reflecting a broader systemic or like a failure in the design of the trial itself. And sometimes we don't get the perspective of these people of why they dropped out or why they don't want to participate in clinical trials. So it is important to have them in a roundtable to understand those barriers. And it may be uncover stuff that even us as advocates or as community members were not able to see. So I think it's important to have people who don't want to be part of clinical trial or people who have dropped out of clinical trial to also be part of these conversations.
Absolutely. Thank you. Osei?
Yeah, so I was going to say, and also more of, I would say I've been mentioned that a lot, like the leaders as well, because the leaders are influential in a country that I'm coming from, Ghana, where we have about 76% of our population Christians and 16% Muslims. Religious leaders play a very key role when it even comes to healthcare access. And so these are people that most of the times they are often overlooked when new things are coming in, but they hold, I would say, a lot of influence on the people that would need access to these treatment. And so I would say people that needs to be on the table could be other, influential people, not just the government. I mean, the government is there, but on the ground, it is the opinion leaders, is the religious leaders that needs also to be on the table to be able to, share the experience of the community members, because they are really close to the community team members as well.
Thank you, Osei. No, so it's really, really important to involve them, and I think sometimes overlooked when coming from different parts of the world that have different kind of setups of trust and community. Anyone else wishing to add in, Ketho?
Yeah, just one small point. I do observe that conversations are happening, but it's happening on a very different scale. Like the Ministry of Health and the drug controller might be speaking with each other. The innovator or the generic company will definitely be speaking with the program, with the drug controller authority again. So it's like a one-to-one traffic kind of a conversation happening, but conversation is not happening together. And as well as we, the community, we also we speak with everyone actually, but one thing that I've seen is that there is no interface kind of a healthy and constructive or rather critical discussion about access between the community and the program implementers at the national level, who are at the topmost level, who designs the policy, who updates the guideline, who liaise with the global fund, for example. So what I would really see something happening is that conversations can happen, but I think an interface conversation between the community representative and the national program implementers is going to be very, very important. So that is what I want to add. But also one thing that just crossed my mind, since the beginning of this webinar, I was thinking, what defines a community? And also, what is a CSO? Because again, I see that there's a confusion of identity crisis as to who do I represent. For me, I would say a community is someone who has undergone the problem himself, herself, and is now having a lived experience or a past experience with any sort of disease. Whereas a CSO is a group of collective concerned people who comes together and forms an organization. But sometimes at the global level, national level, every CSO speaks and act like a community. So what is the boundary between a CSO and a community? So that is something that I just want to bring into the table of discussion also. But to finally add again for now, that the word that Satyam brought out, and I believe my two of my other colleagues also brought out about tokenism. Now there is tokenism, no doubt, but still, again, there is another thing called the dummy representative, who are handpicked by any company or who are handpicked by any uh, program policymakers to represent the community, but that person is just being put on the chair as a dummy representative to append his or her signature to be eligible to say that, yes, we have had a meeting, we have invited that person, he, she came and attended, and this is how we include the community. So community are also being used in a very cheap manner up to some extent. And even some other people also have known how to play around, play the politics around with the community. And many of the community are also not aware of who he or she represents and what important role that he or she can play and represent, and therefore are falling into the hands of that kind of uh, politics also. So that is something that I just want to lay out for all of us to have some thoughts on it. Not today, but maybe in the near future.
Oh, so it's a really good question about that real and non-tokenistic and non-dummy kind of representation and involvement from in all stages of this, I think. Yeah, I do think we have a few minutes if anyone did want to add to that particular point, but I think I think we were at the end of the kind of key questions. Second. Yes. I don't, unless anyone else had any additional points there to add to that particular aspect of, I think we can move to the close. So I'll just share my screen in terms of just a bit of an outro and a thank you. So just to note, very slow. So the recordings from the session is going to be made available online. We'll be putting out for all of our the CELT Global Health LinkedIn and YouTube channels. We'll also be utilizing the discussion that we've had today to prepare a summary piece that we'll be aiming to get published over the next few months. And we would like to get input from the panelists on that, which will be in touch shortly after the session to arrange. And as I had mentioned, that last point about who we involve in the conversation and some of those conversations to be had, and workshopping some of these different difficulties and successes and kind of access is something that we are planning to do in CELT, and been putting in applications for funding to try to organize relevant kind of sessions like that. So do keep your ears to the ground, because we will be updating more on that with coming months, hopefully. So our next LA Link is going to be focused around emerging long-acting technologies for global health applications. It's planned for June, early July, and a specific date and title and other details are going to be shared over the coming months via CELT News and social media as well. We have also actually recently just announced our new conference, the LA Global, abstracts have just opened for that. I'm not sure if some of you may have seen on the LinkedIn and or socials of CELT, but yeah, we're quite excited to have a range of different topic areas across the long-acting space, everything from pediatric and maternal to modeling, and we're hoping for additional workshops focused on around areas such as access and relevant points like that. And finally, I just want to say thank you to all of our panelists, everyone who's joined in as well today. It's been a really, really interesting and enlightening conversation. It's amazing to have a conversation with people from across the world like this and to hear your different perspectives. So I just want to say a heartfelt thank you from CELT to all of our panelists.
So thank you so much, Andrew, for having us. Really appreciate it.
Much appreciated. Thank you, Osei.
Thank you so much.
Thanks, Andrew.
Thank you very much.
Thanks,
Thank you,
Andrew.
Belinda.
Okay then. Thank you very much, everyone. Bye-bye.
Okay.